Hi class, in this lesson I will review bipolar disorder or BPD. In the past this disease was called manic depressive disorder, so you may have heard that term before. Nowadays we just use the term bipolar disorder. Between 3 and 4% of the population experiences this disease. Lucky for you guys, there really is one main drug that's used for this. So there's one new drug that we're going to talk about during this lecture. And there are a couple of other drugs that also are pretty effective at treating bipolar disorder, but luckily you guys are already familiar with them. They're both anti-epileptic drugs. And so let's go ahead and get started. Objectives are listed on the slide. They're also listed in Blackboard. There's no new vocabulary. As you can see, the screen is empty. And some general concepts. So bipolar disorder is associated with mood swings. It's the disease itself is really characterized around the patient's mood. Is it an elevated mood? Are they experiencing what we would call mania, or extremely low moods, which we would characterize as depression? The prevalence of bipolar disorder is equal among males and females, and as I already mentioned, it affects about 4% of the population. Characteristics of bipolar disorder. So there are a variety of different characteristics. This disease state, patients can kind of experience highs and lows. They can cycle in between different states of well-being, so to speak. But so these are the four major characteristics of the disease. The one that most people think of when they think of a patient with bipolar disorder is mania. And so this is characterized by euphoria, agitation, irritability. The patients don't need to sleep. They talk really quickly. They've got a kind of a very inflated self-confidence or self-esteem. They don't always make good decisions. Sometimes they even have delusions or hallucinations. Hypomania, on the other hand, is similar to mania in that the patients are still somewhat euphoric. They may not need sleep, but it's not as extreme as a manic episode. The other characteristic of bipolar is major depression. So this is kind of the other end of the spectrum. And then, of course, this would just be depressed mood, loss of pleasure, just kind of loss of a desire to engage in pleasurable things. And then finally, there could be mixed episodes. And so patients could cycle in between these manic symptoms into depression symptoms. And sometimes they're even kind of seemingly happening simultaneously. And that's about all I'm going to talk about for the background of bipolar disorder. I know that you guys will go over this in your psych class in much more detail. So I'm really just going to focus on the pharmacology for the rest of the time that we have on this subject.
So let's review the drug therapy for bipolar disorder. So there are three categories of medications that are used for bipolar disorder. The most important category, and what this lecture is all about, are the mood stabilizers. The mood stabilizers are the drugs that actually treat the underlying disorder. These drugs will relieve symptoms. They will prevent recurrence of manic and depressive episodes, and they do not worsen symptoms of mania or depression. So these drugs are really the mainstays of therapy. Now, the mood stabilizers fall into two broad categories: lithium, and so this entire lecture really will be spent on reviewing lithium. Lithium is a drug that's been around for some time. It's been in clinical use in the United States since the 1970s. It's not a drug you're going to see frequently because it's really used mostly for bipolar disorder. There are a couple other indications, but its primary use is for bipolar disorder. But you will see it. And the thing of it is, when you see it, you gotta really pay close attention to these patients because lithium is a dangerous drug. It has a narrow therapeutic index. However, it is highly effective for bipolar disorder. But the patients on lithium have to be monitored closely. They need good education. They need to be active participants in their therapy. So we're going to spend a lot of time talking about lithium. The other group of mood stabilizers are the anti-epileptic drugs. These are becoming first line. Traditionally, lithium was first line, but in the past several years, the anti-epileptic drugs are becoming more and more popular for treatment of bipolar disorder, and there's more and more data available for treatment of bipolar disorder, especially with the first one that I have bolded on the slide, divalproex, also known as valproic acid. I am not going to review these anti-epileptics in this lecture, other than to tell you that they are used for bipolar disorder and specifically as mood stabilizers for the treatment of bipolar disorder. Um, the pharmacology of these drugs is reviewed in the anti-epileptics lecture. But like I said, I do want you to know that these drugs are used widely for bipolar disorder. They are somewhat less toxic than lithium. They're still toxic, they still have toxicities associated with them. But in terms of management, they're a little bit easier to use than lithium. And there is actually some data for certain types of bipolar disorder for these drugs, for some of these drugs to be even more effective than lithium. Uh, so, mood stabilizers, mainstay of therapy. The other two classes of drugs that could be used are the antipsychotics or the antidepressants. The antipsychotics are used to control symptoms during a severe manic episode. Even if the patient is not experiencing psychotic symptoms, these drugs may be used in addition to mood stabilizers for patients in severe manic episodes. The antidepressants also may be used specifically for patients that are experiencing depression. But I think one of the key points is that they're rarely used without a mood stabilizer. And the worry is that if the patient's depression is treated, if they're not also on a mood stabilizer, then they may swing to the other end of the spectrum and begin experiencing mania. So patients with bipolar disorder may see them on an antidepressant, but they should also be on a mood stabilizer in the majority of cases. I think this goes without being said, but I suppose I should mention it. Non-drug therapy for patients with bipolar disorder is also very important. So ideally, patients that are on medications are also receiving psychotherapy as well. And you can read about psychotherapy and other non-drug therapy measures in your textbook on page 366. So the remainder of this lecture, we're going to spend our time talking about lithium.
All right, so let's talk about lithium. I think I've mentioned to you guys before, if I've got a slide and there is or I'm sorry, if I have a lecture and there's a drug and that drug's got 6 or 7 slides, that means in general it's a super important drug. So lithium is a very important drug, not because it's used all that frequently, but mainly because number one, for patients with bipolar disorder, this is, especially with euphoric mania, this is the drug that's going to be used. But number two, this drug has a narrow therapeutic index. It's been around since the 70s. Exactly how it works is not entirely known, but it's thought to somehow be related to influencing the reuptake of serotonin and norepinephrine. The primary uses for bipolar disorder, although there are some other uses such as alcoholism, bulimia, schizophrenia. And as I mentioned, this drug is first line therapy. And I would say even up until recent years, lithium was the drug of choice to treat all forms of bipolar disorder. Because some of the anti-epileptic drugs have been shown to be effective, those drugs have in many cases replaced lithium just because they're a little bit easier in terms of fewer side effects and such, which says a lot because if you remember the anti-epileptic lecture, I said that these drugs have a lot of side effects. The difference is lithium has even more side effects, and lithium has a very narrow therapeutic index. In terms of it's first line therapy still for all patients with euphoric mania, but it still could be used in patients with other characteristics of bipolar disorder. It starts to work in about a week, and generally within 2 weeks, the full effect is seen. And this is a drug that levels are drawn for. That's just the way that it's given. There is a typical starting dose, which is 300 milligrams twice a day, but that is rarely the dose that the patient will stay on. In many cases, the patient, actually, I would say in all cases, the patient is going to be monitored closely for the first couple weeks. The levels will be monitored probably every 3 or 4 days, and the dose will be titrated based on those levels, because the levels actually correspond very closely to therapeutic effect as well as production of side effects. And I'll talk about that in a few minutes. The therapeutic range for this drug for the acute treatment phase is a little bit higher than the maintenance treatment phase, but you can see the ranges. I have them listed on the slide. Now, once you get through that acute phase where you're where you're measuring levels every couple days, once the patient's in a maintenance phase, levels are typically drawn every few months, like every 3 months or maybe even every 6 months if the patient um, has been stable on the medication.
So I already started to talk about pharmacokinetics, but just to continue the discussion, you should know lithium has a short half-life. It is usually dosed several times a day, 3, even 4 times a day. The minimum dosing would be BID because it does have a short half-life, specifically for patients that are being treated for bipolar disorder. There are extended release preparations. Even those preparations are usually administered twice daily. Elimination of lithium is via renal excretion. So anything that decreases renal excretion of this drug could cause the drug to accumulate, and that could lead to toxicity. Very important to assess renal function. Additionally, anything that changes sodium or fluid intake can also change lithium plasma levels. Because lithium is very similar to sodium in terms of the way the body handles those, you all may remember lithium is an element, and if you look at the periodic table, lithium and sodium are right next to each other. So in terms of the way the body handles lithium and sodium, it's very similar. If the body detects that sodium is being lost, it's going to try to hold on to sodium. It's also going to try to hold on to lithium. So any changes in sodium, especially when the body detects that sodium is being lost, is going to lead to increases in lithium levels. Fluid intake can also lead to increases in lithium levels because if the patient becomes dehydrated, again, the body's going to detect dehydration and hyponatremia, and the body's going to want to hold on to lithium. So good fluid intake is very important. Hyponatremia, hypovolemia, both of these scenarios are going to decrease lithium elimination, leading to accumulation of lithium, which can very rapidly lead to toxicity. Even things like being outside on a really hot summer day and sweating profusely, that could lead to lithium toxicity. Additionally, drug interactions. So either drug-drug interactions or drug-food interactions. So thiazide diuretics, in fact, diuretics in general, thiazide diuretics, loop diuretics, these can cause hyponatremia. That can lead to lithium toxicity. NSAIDs also influence fluid handling and sodium handling in the kidneys and just kidney function in general. NSAID use can lead to lithium toxicity. ACE inhibitors, as we've talked about, those can also lead to lithium toxicity. And then salt-restricted diets as well. So patients on lithium should not be on a salt-restricted diet. Generally, patients on lithium should be referred to a dietitian for counseling and instruction on proper diet.
In terms of adverse effects, I have these broken down by adverse effects that you expect to see when the drug is in the therapeutic range versus adverse effects you would see when the drug levels are in the toxic range. So those that you might see when the drug is in the therapeutic range, polyuria or thirst as well. And this is caused by antagonism of antidiuretic hormone. So lithium actually kind of interacts with that and can cause polyuria and can cause thirst, increased thirst. The drug can also cause hypothyroidism, and that you can see in up to 35% of patients. And so this can easily be treated. The patient would have to take a medication to treat hypothyroidism. The medication that is used to treat that disorder is called levothyroxine. We will talk about that medication towards the end of the semester. This drug can also cause tremors, can also cause some skin problems such as acne. And when the drug's used long term, it can actually lead to renal dysfunction. And that's important to know because the drug's cleared renally. And if the patient is starting to have decreased renal function, that means they're going to start accumulating the drug and they could potentially become toxic. Finally, this drug is teratogenic. And so making sure that patients who are on this drug are using appropriate birth control is very important. And there are safety concerns. So I said that I would talk about adverse effects that are seen when the drug is outside of the therapeutic range or higher than the therapeutic range. So when you see blood levels above 1.5 MEQs per liter, that's when you start to get very concerned because that is, once you get outside of above that number, that is when the toxic effects start to be seen, and really they kind of progress from not great, pretty annoying kind of things all the way up to potentially death. So starting out with severe nausea, vomiting, or diarrhea. This is kind of just below the therapeutic range, but then as you get above that therapeutic range, you could see things such as coarse tremor, uh, EKG changes, even higher levels, like levels above 2, you could see ataxia, stupor, coma, even death. And levels above 2.5, those are kind of across the board. Those are going to be considered absolutely life-threatening. They most likely, the patient's going to be experiencing seizures, and probably they'll die as a result because those levels just aren't compatible with life. In terms of treatment, there's no antidote, unfortunately. So treatment is supportive. Obviously, discontinuing the drug as soon as possible, supporting the patient in terms of some of these effects that are seen. Um, if the patient if the levels are really high, and sometimes hemodialysis will be initiated. So that's another possibility. RN implications, very, very, very important. High quality patient education on how to maximize the therapeutic effects and how to minimize adverse effects. So being familiar with, things like promoting adherence, making sure the patient understands they need to take the drug even when they feel better, making sure that they understand they have to get their levels drawn, and then giving advice on how to minimize some of those side effects.
So, just to reiterate some of those key points, I know I talked about this on the last slide, but the nursing implications with lithium are extremely important. Again, this is a narrow therapeutic index drug, and monitoring is of the utmost importance, as well as high quality patient education. So, for monitoring, we're looking at both the clinical response as well as potential adverse effects. And then, in addition to that, all of these patients should have plasma drug levels. So, we're not looking at one or the other, but we're looking at kind of the whole picture together. Looking at the plasma lithium levels, are they within range? What does the patient's serum creatinine and creatinine clearance look like? Monitoring their electrolytes. Also looking for evidence of adverse effects. So we talked about a variety of different adverse effects that could occur with lithium, and especially some of those adverse effects that could be an early sign that toxicity is imminent. And it's very, very important to provide the patient with high quality patient education. So you want to make sure you go over all of the key points. For these patients, will probably, and for all patients, go over these key points on multiple encounters. And some of the things you want to talk to your patients about are how long before they may see effects. Remember, it takes a few days to see any effect, usually, usually several weeks to see the full effect. It's important to explain to them to take the medication exactly as prescribed, and then, of course, explain to them what will happen if they don't. The importance of fluid and sodium. Remember, explaining to the patient that fluid intake and sodium intake can have a huge impact on their medication therapy. It can cause them to have very bad side effects very quickly if they're not following the advice around fluid and sodium intake, minimizing dehydration, and then, of course, referring them for nutritional counseling would be, in most cases, very helpful. And then talking to them about toxicity very explicitly, that this drug is very effective, but if it's not taken properly, and if when things occur, sometimes toxicity can occur, but explaining to the patient what to look for so that they can seek treatment very quickly before it becomes too serious. So some of those early signs and symptoms that they should look for, and then of course if they're experiencing them, they need to call their provider, reminding them of the importance of their lab appointments, and kind of everything related to toxicity, and just being very clear with the patient that they do have a responsibility. With a lot of times with patients that have bipolar disorder, if possible, including family members or other support that they have in the education is wise if that's possible.
Okay, so that's it. That concludes our discussion of drugs to treat bipolar disorder. If you have questions, please post them to the discussion board. And remember, for bipolar disorder, there's really just one new drug that we were talking about, which is lithium. And I spent a lot of time on that drug. So I would definitely recommend, when you are studying for exam 2, that you spend a good amount of time really getting to know lithium and understanding the issues with that drug, the effects that you might expect to see, how to maximize your therapeutic effect, and how to minimize your adverse effects. The other drugs, the antipsychotics and the antiepileptics, you should also be familiar that those are used to treat bipolar disorder. But in terms of the pharmacology, you'll already be familiar with that because we went over those when we talked about antiepileptics and when we talked about the antipsychotics. All right, thank you for listening.
Okay, so quick case study. Now, I'm not going to go through the answers to this case study. I will post them, but I do want you guys to take a little bit of time and work through this. So it's a 24-year-old woman. She's recently been diagnosed with bipolar disorder, and she has new orders to receive lithium. So what should you assess for this particular patient prior to administering the medication? Obviously, there's some standard practices that you'll perform, for any drug. But I want to know some of the baseline determinations that you would make prior specifically to administering lithium. And then you're going to do some teaching for this patient. So what elements or what information would you include in your teaching plan? This particular patient tells you that she's afraid to take the lithium because you had explained that there was some blood work involved. So she heard from a family member that she had to have blood work done every day, and she doesn't like needles, so she was uncomfortable. So what would you tell her? How would you respond? So again, I want you to go through this case study in its entirety, take some time, think through it, and then I will have the answers posted on the Blackboard site. All right, I will go through the answers to the questions though. So, question 1, a patient who is diagnosed with bipolar disorder is prescribed lithium. To monitor for lithium toxicity, the nurse should observe the patient for which signs and symptoms. So, look through the choices. I'll give you a moment to look through those and think about them. You can even pause the tape if you'd like. So, hopefully, you had some time to come up with the right answer. Hopefully you came up with the same answer I came up with, which is C, polydipsia, slurred speech, and fine hand tremors. So these are symptoms of lithium toxicity. Other symptoms: nausea, vomiting, GI upset, diarrhea. Remember, I said some of the kind of GI symptoms are earlier signs that the patient is beginning to experience toxicity. Other things like clonic movements, hyperirritability of the muscles, muscle weakness, hypotension. These are some other signs. But those GI symptoms, polydipsia, slurred speech, these are some of the earlier symptoms that you can, well, actually fine hand tremors, slurred speech, polydipsia, especially the tremors. Uh, these are when the patient is kind of getting close to the toxic level. So the other things that are on the slide, none of those are really indicative of lithium toxicity. Question 2, a patient with bipolar disorder is prescribed lithium. Which statement, if made by the patient, indicates a need for further teaching? So remember, with this type of question, you're looking for what is wrong. So look over the choices. I'll give you a moment. All right, so hopefully you chose D. I will reduce my salt intake while taking this medication. So lithium will accumulate if sodium is restricted, so that would definitely be wrong. A, B, and C are all correct responses. Question 3, the nurse cares for a patient who's receiving lithium. Which medication, if prescribed by the healthcare provider, should the nurse question? So look through that list, and again, you can pause the tape for a moment if you'd like. All right, so if you said C, furosemide, you are correct. So remember I said diuretics promote sodium loss. So if the sodium level is low and the renal excretion of lithium is going to be reduced, and lithium levels will accumulate or increase. So lithium will accumulate, which means the levels will increase, and this can result in toxicity. The rest of those medications don't generally affect lithium. All right, and the last question, question 4. Nurse prepares to administer lithium to a patient. Which lab results should be assessed? So look through those. Okay, so if you said A, creatinine clearance, you would be correct. Now, creatinine clearance in and of itself is not necessarily a lab result. The creatinine clearance is based on the serum creatinine, which is a lab result. The creatinine clearance has to be calculated. Nowadays, the electronic health record usually will provide you with the result of that calculation. But creatinine clearance is a measure of renal function. So this is something that we could look at to determine whether or not the patient has normal renal function or not. All right, so if you have any questions, please feel free to post them to the discussion board. Thank you.